Von Willebrand disease. This is another type of coagulation disorder that causes bleeding and is one of the most common hereditary disorders seen in 1 to 2% of general population. Most centers report more women than men because menorrhagia is a major symptom that make women seek treatment. It is an autosomal recessive or autosomal dominant, and we have different types. In type 1, there is mild to moderate quantitative deficiency of von Willebrand factor. It is the most common type, 85%. Type 2 is qualitative deficiency of von Willebrand factor. Another subtype of type 2 is the platelet type or pseudo von Willebrand disease, in which there is abnormalities of glycoprotein 1b receptor on platelets, which is hyperfunctioning and bind von Willebrand factor spontaneously, causing thrombocytopenia. The type 3, there is complete absence of von Willebrand factor. Type 2 can be classified into 4 subgroups. 2A, lack of high molecular weight multimer. Type 2, partial loss of high molecular weight multimer. 2N, defect in von Willebrand factor 8 binding site. And 2M, functional defect in von Willebrand factor. The clinical feature is mainly that of mucous membrane bleeding, recurrent epistaxis, menorrhagia, which is not always regarded as abnormal because the whole family have the same problem, the same like epistaxis, post-operative bleeding, especially after mucosal surgery for tonsillectomy or wisdom tooth extraction, bleeding after any tooth extraction, and in type 3, which is usually severe, the bleeding may be in the joint like hemophilia. Patient with von Willebrand disease may have GI tract telangiectasia, leading to major bleeding with frequent hospitalization if the condition is severe. In type 3, bleeding may be more profound. Those patients are diagnosed since early life due to severe bleeding that may cause shock. The type 3 may have joint bleeding and CNS bleeding. Because von Willebrand factor is an acute phase reactant protein, stress will increase its level. So, patients will not bleed with procedures associated with major stress such as appendectomy and childbirth, but may bleed excessively with the cosmetic surgery or mucosal bleeding. Bruises may decrease during pregnancy because the level of von Willebrand factor double and triple during pregnancy. Von Willebrand factor level can be influenced by external factors, and there is variation in the level according to the blood type. Lower level seen in people with group O. Stress, exercise, and pregnancy, as I said, increase its level. Therefore, a single normal von Willebrand factor does not necessarily rule out the presence of von Willebrand disease. Certain diseases such as hypothyroidism and certain medications such as valproic acid can lower the von Willebrand factor in the affected patients. The lab findings show prolonged bleeding time. The PT is normal, the PTT is normal or increased according to the type. There is defective platelet aggregation with ristocytine. Both bleeding time and PTT may be normal in type 1, and a normal result on screening does not preclude the diagnosis of von Willebrand disease. If the history is suggestive, von Willebrand testing should be done, including quantitative assay of von Willebrand antigen, testing for von Willebrand factor activity, it means ristocytine cofactor activity, determination of von Willebrand structure, von Willebrand multimer, and platelet count. Although platelet count is normal in most patients, the type 2 disease and platelet type pseudo-type von Willebrand disease have low platelet count. And as we said, the level vary with the group. Von Willebrand factor gene is located on chromosome 12, and this will help in prenatal diagnosis looking for the gene mutation. Differential diagnosis should be done from causes of abnormal platelet number, causes of platelet dysfunction, abnormality of blood vessels, means vasculitis, and child abuse. Complications in adolescent female menorrhagia is a problem that may cause severe anemia, either acutely with signs of hypovolemia or chronically with iron deficiency anemia. In type 3, joint and muscle bleeding, like hemophilia, may be a complication. For the treatment, avoid aspirin and non-steroidal anti-inflammatory drug. In type 1, the DDAVP given IV or intranasally will cause release of von Willebrand factor from the endothelial cell up to 5-fold and so stop bleeding. In type 2, the released von Willebrand factor after DDAVP also high but is dysfunctional. So it is not always effective, and patients require von Willebrand factor replacement therapy using plasma-derived von Willebrand containing concentrate that also contain factor 8. 1 unit per kg will increase plasma level by 1.5%. In type 3, the released von Willebrand factor after DDAVP also high, but there will be thrombocytopenia causing more bleeding, and those patients usually respond to the infusion of von Willebrand factor. In 2M, the DDAVP cause increase in von Willebrand factor and factor 8, but von Willebrand factor has no sufficient activity to control bleeding, so von Willebrand factor replacement is needed. In 2N, a trial of DDAVP is indicated to assess the response and half-life of von Willebrand factor and factor 8 after infusion. Von Willebrand factor replacement is usually effective. So, DDAVP only of benefit in type 1, while in type 2 and its subtype von Willebrand factor replacement is necessary. In type 3, may benefit from platelet transfusion. In platelet type, pseudo von Willebrand factor also require platelet transfusion. Cryoprecipitate is used when von Willebrand factor is not available, and antifibrinolytic agent used when there is nosebleeding or dental extraction. A blood transfusion is necessary.